Welcome to PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons. It's greatly appreciated. In this video, we're going to discuss the measurement of vital capacity during lung volume testing. The 2023 European Respiratory Society American Thoracic Society Technical Standards recommends one method of measuring vital capacity during lung volume testing, and I'm going to try to convince you that this is not the best approach. While lung volume testing is not as useful as spirometry and diffusion capacity in most cases, there are clinical scenarios where it is important to measure lung volumes for clinical decision making. And of course, if you are making these measurements, you want to make sure that you're doing it correctly and reporting accurate data. To measure lung volumes in all of the subdivisions, you need more than a spirometer because a spirometer alone can't be used to determine residual volume, functional residual capacity, and total lung capacity. There are three common methods to determine functional residual capacity. The first and most accurate way to measure lung volumes is by plethysmography, or the body box method, where changes in alveolar pressure, which are approximated by mouth pressure, are plotted against changes in lung volume, which is approximated by the cabin or box pressure during gentle pants without airflow. Let me give a brief description of how plethysmography works. When the alveolar pressure is plotted against the change in lung volume, a best fit line is drawn, and the slope of that relationship determines the thoracic gas volume, meaning the volume of air trapped in the lungs when the shutter valve is closed, for panting. The lambda symbol that you see here at the bottom equation represents that slope. So, if you had a 30-degree angle and the rise was less than the run, a tangent of 0.58 as depicted by the dashed line here, you would have a larger volume of air than if you had a 45-degree angle, where the rise is equal to the run, a tangent of 1 depicted by the solid line. And if you had a 60-degree angle, so the rise is greater than the run, a tangent of 1.7, you'd have a smaller lung volume as depicted by the dotted line here. Another method to measure lung volumes is by helium dilution, in which FRC is determined by the dilution of helium after several minutes of breathing in a closed system. In this example, the helium concentration depicted by the blue tracing starts at a little over 12% and achieves equilibrium just under 10% after a period of tidal breathing. Due to greater dilution, the helium concentration at equilibrium will be lower for a larger FRC than a smaller FRC. The third method to measure FRC is nitrogen washout. We may not know what the FRC is, but we do know that 79% of it is nitrogen. The orange tracings depict the nitrogen concentration as the patient breathes 100% oxygen until the nitrogen concentration reaches 2%, and then the FRC can be calculated. While great care is exercised to record an accurate FRC, it is the vital capacity that determines the subdivisions highlighted inside the red box, and the vital capacity is required to calculate both total lung capacity and residual volume. It is therefore just as important to record an accurate vital capacity as it is to measure an accurate FRC. The 2005 ATS-ERS lung volume standards describe two acceptable ways to measure vital capacity during lung volume testing. The preferred method for measuring vital capacity was a series of tidal breaths with a stable FRC. The patient would then exhale to residual volume. When a plateau is reached, they would take a full inhalation up to total lung capacity. The alternate method for measuring vital capacity was once again a series of tidal breaths with a stable FRC. The patient would then be instructed to do an inspiratory capacity maneuver up to total lung capacity, then exhale fully down to residual volume. In 2023, the ERS and ATS published an update to the lung volume testing standards, and in this standard they recommended one way to measure vital capacity during lung volume testing. I'm going to read their recommendation now. For standardization, the method that is expected to be achievable by most patients is recommended here. Immediately after the acquisition of the FRC measurements, an inspiratory capacity maneuver is performed to measure the TLC in a linked manner. The inspiratory capacity maneuver is followed by a linked slow expiratory vital capacity maneuver to residual volume. This is the figure that's included in the technical standards as an example. And as you can see, after several tidal breaths, this is used for plethysmography, so the shutter is closed. After the FRC is measured, the patient takes a full inhalation up to TLC and then exhales fully down to residual volume. I'm not a big fan of this recommendation because this is a pattern that you see very often where the patient is doing tidal breathing. Right here, the valve is closed to measure the VTG or the FRC. The patient's instructed to take a full inhalation in and then blow all the way out, just like the technical standards say. But when they take a second deep breath in, you can see they achieve a higher lung volume than they did just after the first inspiratory capacity maneuver. This shows the impact of this phenomenon on the measured TLC. So as you can see here with just the tidal breathing, the valve is closed, the VTG is measured, the patient is instructed to do a inspiratory capacity maneuver, blow all the way out to residual volume. But because I do an inspired vital capacity at the end of that, you can see here that the patient achieves much more volume, as depicted by the red line, in a higher TLC. The other problem you may run into with doing the inspiratory capacity maneuver as recommended in the 2023 technical standards is after the patient takes a deep inhalation and they blow the air out, they may have airway closure. This is typical in obese patients. As you can see here, the FRC line is depicted by the red line, and where they plateau is the blue line. So they're not getting back down past their tidal breathing because of airway closure. So in these patients, I do what was described as the preferred method in 2005, where the patient does tidal breathing, the shutter is closed for the VTG, then I have the patient exhale first to residual volume and then do an inspired vital capacity maneuver. So in most of my patients, I will do what I call the combined maneuver, where I'll have them do the tidal breathing, do an inspiratory capacity maneuver, exhale down to residual volume, but I always do an inspired vital capacity maneuver at the end. Not in this case, but as I showed before, and many times they'll achieve a higher lung volume in that second deep inhalation. Key points: vital capacity is a critically important determinant of lung volumes and capacities. In my opinion, a one method fits most approach to measuring vital capacity is not ideal. What I recommend is using the method that works best for each individual patient. As I showed, in obese patients where there's airway closure, you may do better using the 2005 preferred method, where you have the patient exhale to residual volume first, followed by an inspired vital capacity. Thank you for watching PFT Tutor with Jeffrey Haynes. Please click the like, subscribe, and notification buttons, and we'll see you next time.